Now coming to the next condition, that is the contact granuloma. It is also known as contact ulcer or the kiss ulcer. Now it is a benign lesion. It is totally a benign lesion. It is not a pre-malignant lesion. Couple of people, they misdiagnosed it as a pre-malignant or a malignant condition. So always remember, the contact granuloma or the contact or kiss ulcer, they are totally benign lesion, and they are located in the posterior third. They are located in the posterior third of the vocal cord, true vocal cord area. So it does not undergo any malignant change. That is very important. It does not, it is not a pre-malignant condition, so it does not undergo any malignant change. The etiology of such patient, the patient usually present to us with a the hoarse or a husky voice or irritation in the throat. So etiology can be that such patient, they may have undergone intubation, or there may be a history of vocal abuse or a laryngopharyngeal reflux disease, which is a very it is a underdiagnosed condition. So LPR basically is one of the most common etiology of contact ulcer, and it can be idiopathic also. So the clinical features, as I said, there will be the voice will be hoarse, it will be husky, and there will be a irritation in the throat. So if now you see this condition, this is a picture. So I'll just zoom it for you. So there is a heaping up of the epithelium. So there is a heaping up of the epithelium, and this, why this condition is happening, it can be because of intubation, it can be idiopathic, it can be because of the LPR, that is laryngopharyngeal reflux. If you know the posterior part, this is the part, it is in continuation with the cervical esophagus. This is the piriform fossa. This is the piriform fossa or piriform sinus. This is the true vocal cord. It is true focal cord, and this is the subglottic area. This is anterior and this is posterior, and this is basically the interarytenoid area. This is the interarytenoid area. So what is happening is that because of the acid reflex, the acid is coming from the piriform sinus or the post-cricoid. This area is the post-cricoid area. When the acid is coming from the post-cricoid area, it is refluxing. It causes a heaping up of the epithelium, which mimics, it basically mimics a malignancy, but it is not a malignant condition, and it also does not undergo a malignant change. So on indirect laryngoscopy, what we will see? On indirect laryngoscopy, we will see the heaping up of, write down beta, on indirect laryngoscopy, we will see a heaping up of red or grey granulation tissue in the interarytenoid region. Remember, it is present only in the posterior part of the larynx, the endolarynx, that is the posterior one third of the vocal cords and the interarytenoid area. And later, sometimes if there is a heaping up of this epithelium, if there is a heaping up of the epithelium like this, that is in the posterior third of the vocal cord, if there is a this is a heaping up of the epithelium that is seen. So later, when the patient is speaking, continuously speaking or phonating, there can be a formation of depression on the opposite. There can be a depression on the opposite vocal cords. So this is known as the contact ulcer or the kiss ulcer. It is not a true ulcer. So if there is a continuous the continuous hammering of the vocal process, as in talking or in phonating, it forms a contact ulcer, which is also known as kiss ulcers. It occur when lesion involve both the vocal cords. So you will see on one side, you will see heaping of the granulation, and on the other side you will see a contact ulcer or the kiss ulcer. But one thing you should not forget, that this is the contact granuloma is not a malignant condition, and it does not have the capability of undergoing a malignancy. And this basically, if it slams, it is present in the posterior third of the larynx, and if it slams on the opposite cord also, it creates a depression, which is not a true ulcer. It creates a depression, which is known as the contact ulcer or the kiss ulcer. So it is known as the contact granuloma. Now what is the treatment? The treatment part, it consists of the speech therapy, very important. if you have diagnosed this condition by indirect laryngoscopy, you must subject that patient to undergo a voice therapy. The patient should be asked to manage their stress, because in stress there occur a lot of acidity. So that stress and the ultimate the acidity which occurs because of stress, it will lead to LPR, and this patient should also be given H2 antagonist or antacid to counter their acidity. And we must do a microlaryngeal excision of the granuloma, and we must send it for histopathological examination. So we will be doing a microlaryngeal surgery in this patient as well, and we are excising this granuloma, that is the contact granuloma, and sending it for histopathological examination. As the histopathological examination, write down beta, the histopathological condition, it will, the histopathological evaluation, it will differentiate this condition from tuberculosis of larynx and the carcinoma of larynx. So histopathological condition, basically it examination, it basically differentiate that it is not a carcinoma which we are seeing, and it is not the TB which we are seeing. So on histopathological evaluation, you will the report, you will see that it is only a hyperkeratosis, it is not a malignancy. So this was about the contact granuloma. Now coming to the keratosis laryngis, which is also known as leukoplakia. Now on the contrary to contact granuloma, keratosis laryngis or the leukoplakia, this is a pre-malignant condition. Very important, this is a pre-malignant condition, whereas the contact granuloma was not a pre-malignant condition. So this condition is a pre-malignant condition, and the etiology of this condition is the people who smoke. So smoking is the etiological factor for keratosis laryngis. Now you can see this here in this, the patient is having the leukoplakia. There is a leukoplakia of both the vocal cord. You can see the whitish patch. This is the arioepiglottic fold. This is the arioepiglottic fold, and this is the post-cricoid area. This is the right piriform sinus. Right piriform sinus. You can see here the false vocal cord also, but you can see that on the true vocal cord there is a whitish patch, and on it is encroaching the false vocal cord also. So this condition, basically these are seen in the smokers, and this is also known as the keratosis laryngis or the leukoplakia of true vocal cord. And what is the management? And management is that we will do again a microlaryngeal surgery. We will strip, or we will decortication, we will do the decortication of the vocal cord, followed up by the close follow. We will convince the patient that they should stop smoking after we strip this condition, and this leukoplakia should be sent for subjected to histopathological examination, in which the report will come that this is not a malignancy, this is a leukoplakia. But as this condition is a pre-malignant condition, so histopathology of whatever leukoplakic patch which we have excised from the true vocal cords or from the false vocal cord, we must subject it to a histopathological examination.